Hi everyone, it's Dr Andrew Orr here, and I'm here as part of myself and experts program, but also part of Endometriosis Awareness Month for 2021. And I have the lovely Dr Philip Hall with me today. Thanks for coming on.
Andrew, it's a pleasure. It's always a pleasure to talk with you.
It's about time you came on.
Yeah. Anyway, I'm here today and I'm really looking forward to talking with you.
Oh, that's good. For those of you that do or don't know Dr. Hall, he's a well-renowned obstetrician gynecologist for
30 odd years.
30 odd years. Woo. He's been trained here in Australia and the UK, spent 2.5 years in the UK training.
Correct.
Is that correct? He's a pelvic specialist as well. He's a senior gynecologist for over 30 years. He also does urodynamics. What don't you do?
I do a lot of things. In fact, I'm pretty busy, but what I have done is concentrate on the things that really add to quality of life for women.
And that's important, which we are going to talk about. The other very important thing that we need to talk about with Dr. Hall is he is an advanced trained surgeon. He also does a lot of work around the long-term interest in fertility, especially for those couples that are trying to conceive or may have had endometriosis or difficult cases with pelvic pain and things like that. He's also, his special interest is in the modern management of persisting pelvic pain, which we see a lot with women with endometriosis especially. And we'll also talk about the pelvic floor and the importance of the pelvic floor, because sometimes it's not just endometriosis causing women's pain. And he also does sacroneuromodulation, and we will find out about it. Actually, before we start, talk to us about the sacroneuromodulation and how you got into that, because that's something fairly new, is it? Or
yes, it is, in terms of its availability through support through the pharmaceutical and also the Medicare benefits. It didn't have an item number for quite a while, even though it's been available for 20 odd years. But when the item numbers changed and we could then use this modality initially for the control of urinary leakage and bowel leakage, but it's now morphed into management of pain, which hasn't responded to the more conservative and simpler options.
Which is really, really a good option for women when they have tried everything. You know, they've been through the best surgical interventions, they've been through pain management and medications, and they've tried adjunct therapies and nothing's working. It's definitely good to be able to offer them this.
It's not the be all and end all, but it's certainly another option in the whole gamut of things that we can offer to women. And it's not necessarily used on its own, but we use it in conjunction with pain management, with medications, things like Botox in the pelvic floor for uncontrolled muscle spasm that the physiotherapists can do a certain extent of interventions for that, but it doesn't always work and we need something extra. The other things that we can use it with diazepam, Valium, into the pelvic floor muscles themselves, and that can give a lot of relief of the muscle spasm, which can't be controlled by other means.
It's an interesting thing you brought up about the Botox, and things like diazepam intravaginally and things like that, because a lot of women are specifically waiting from surgery to surgery to surgery.
Correct.
And they think that managing their endometriosis is sitting at home taking pain medications, waiting for the next surgery, when there are lots of things you can do.
Correct. And the other thing that people get hooked on, unfortunately, are the opioid group of drugs, which really are only for post-op surgical pain, not for chronic persisting pain.
Yeah.
And then there's the addiction aspect for that, and the high probability of them getting such dependence on it, they then accidentally overdose. And the opioid crisis in the United States is really very significant. And in Australia, that's becoming more of a problem because people don't necessarily have the right sort of insights into management of chronic pain.
Yeah, and we're seeing that now with the likes of Pain Australia and rolling out the initiatives about the opioid crisis and trying different things that aren't. And now we're seeing other things come into the market like CBD oil, which you've actually done some training in.
Correct. I'm an authorised prescriber of CBD, And that, again, is not the sole thing. It's part of the whole gamut of lifestyle modification, mindfulness, meditation, chemical things, surgical things, so that we can put everything together in a holistic pattern in terms of allopathic medicine. But we also need to use things like herbal medicine, acupuncture, Chinese medicine. So all those things, it's not a single one, this or that. If we can actually bring everything together and put a jigsaw for patient management, it just works so much better.
Yeah, and that's one thing I talk about a lot, and I know you do too, about that multimodality approach, and where we can work together in like a symbiotic relationship where no one's got all the tools, but if we all work together, work with, like pelvic floor physios, work with other surgeons, that because some women might need bowel surgery as well,
or bladder surgery, or both, or physiotherapy intervention, pain management intervention. And no one needs to be excluded in all this, or an approach that says it's only this, it's only that. Life's just not like that.
No, and that's where we see a lot of people probably not go wrong, but they're probably misinformed a lot. And the other area that you and I probably see a lot, the area that is missed a lot, is the psychological aspect. And not seeing a good psychologist or a psychiatrist is needed as well.
And in all of that, lifestyle modification realistically, and if you're actually traveling along and you've had your pain for 7 or 8 years, and that's the duration on average of someone getting from their first symptoms through to the diagnosis of endometriosis, you get into patterns of life. And those life patterns, you obviously need someone who is outside your normal setup to help you work your way through that, and also give you a realistic expectations of what modern Western medicine can do, what Eastern medicine can do, what psychological intervention can do, so that you get the right sort of perspective on things.
That's right. And like you made a very interesting point, because you can't do it on your own. One, you're a bias. You can't give yourself prescription medications. You can't give yourself pelvic floor physio. You certainly can't do your own surgery.
Yeah. And I mean, your GP is really a very good person in all this to help you with the overall pattern of sorting things out. Yeah. Let's say you've got a bladder problem, but not a bowel problem. So you don't go and see the bowel guy. You've got to see the bladder guy with or without the gynecologist, with or without the pain person.
And that's a very interesting thing to say about the GPs, because often, while GPs are just general practitioners, and they mightn't be well versed in gynecology, you can still work with them to then work with your specialist, or seek a referral to seek a specialist.
Correct. And the other things too, there are whole lots of comorbidities that will go on with endometriosis.
Yeah.
So you can't just take that on its own. You've got to put that into the context of the whole person.
That's right. And what do you think are the biggest misperceptions that we see with endometriosis? Obviously, one of them is, like period pain is not normal. Correct. But what else do you see?
Well, I mean, the reality is that there are at least two big groups of patients.
Yeah.
Those who have painful periods, painful bladder, painful bowel action, pain, it just goes on.
Yeah.
So there's that group of people whose symptoms may not have been listened to properly.
Yeah.
And there's another big group of people, and probably 50% of these people are having troubles getting pregnant. They don't have any of these pain symptoms or organ dysfunction symptoms, but they just don't conceive. Or they conceive and they miscarry. Now, that group of people, at least it's close on 50% of those.
Yep.
When we do visualize the pelvis with laparoscopy, we can find they've got quite active endometriosis, and their symptom really is infertility. And unless we do those investigations, we're going to miss out on them, and they're not going to be able to have a successful pregnancy outcome.
And this is why it's important to seek interventions of someone like Dr. Orr, who has done further studies. I know both of us have done a master's in reproductive medicine. And this is the thing we try and speak to women about while we talk about period pain and all the associated symptoms with endometriosis. The significant portion of women with endo are actually asymptomatic.
Correct. And their first lot of symptoms may come up with the, I can't get pregnant or I can't stay pregnant. And that is their first lot of really recognized symptoms. I always feel quite frustrated when someone will come and say, oh, we've been trying to have a baby for 8 years. And every time I go and see someone, they say, oh, well, just keep trying. No, you'll be right. You got any period pain? No. Have you got any this pain? No. Oh, you'll be fine. But in fact, they may not be releasing eggs.
Yeah.
We need to check the partner's sperm count. Yeah. There could be a problem there. And in our community at the moment, sperm counts are really becoming more and more of an issue. We can investigate those, we can treat those, whereas we've really not recognised that in the past. So all those aspects need to be looked at rather than just go home and try to make babies, because it may not work.
Yeah, and sometimes the other part is that if you do go in, and I know you've probably seen this often in your career, especially maybe even with young girls, you might go in and do your laparoscopy and you might not be able to find endometriosis.
At that point.
At that point.
Yep.
And, you know, it might express out at some other stage. So you would have to then rely on your symptoms, you use the clinical studies, your education, go, you know what, I still think this woman has endometriosis. Yes. And treat it pretty much the same.
And I saw someone exactly like that yesterday. She'd had all the symptoms, and I said to her, you know what, I'm not a betting person, but I reckon I could make money on you. We laparoscoped her. We even took some biopsies at the time. And then they came back as inflammation, but no actual endometriosis. Yeah. So you've got to keep that in the back of your mind as, is this an evolving situation? And we have to take really notice that endometriosis is not a clear-cut thing. It's a chronic, inflammatory, evolving process that will affect women through the various stages through their life, from early years with period pain, later pain with menstrual loss and excessive loss, with the eventual development of adenomyosis, which is very similar changes that get into the muscle walls of the uterus. And then the scarring.
What we see.
Yeah, Andrew's got the pictures. So you can see the black dots on the outside, which represent endometriosis, which are very easy to see at laparoscopy. But we need, on the black spots in the muscle wall, we're getting much clearer evidence on MRI and ultrasound to actually identify those things. And in fact, I frequently see reports from general radiologists that say uterus is normal. However, they do report to me the uterus is bigger. They talk to me about a whole other things, and they may say, oh, the uterus is overall bulky. And then people like me who actually ultrasound as well, look at the ultrasound and go, you have got adenomyosis. It's there. And a light bulb goes off.
And it looks like a Venetian bind kind of when you're looking at it.
Yeah, and you can see this, the fuzziness. And in truth, the only way we can diagnose adenomyosis is by the pathologist looking at a uterus that's been removed and being checked out at the histology level of things. But you know, you can't take every uterus out looking for adenomyosis, particularly if someone wants a baby. It just doesn't work.
No.
But we can get good assessments from symptoms plus ultrasound, which we can do in the rooms. And if we've got doubts, we can do an MRI, which is a much more focused situation. But of course, it's got a big price tag attached to it.
And it's interesting, like which a lot of people don't understand. Just for example, state here, say Dr. Orr took a biopsy here, but the endometriosis is here, then it's not going to show anything. And you can't take a biopsy everywhere, can you?
You can look at the areas and think, yeah, that doesn't look right. Yeah. Let's sample that. Let's get the pathologist to help us with that diagnosis. And then there are other times where you think, oh no, that's normal, but let's just take some biopsies, and the report comes back showing microscopic endometriosis.
That's right. And I was sharing with listeners a couple of weeks ago an interesting case. There was one of our colleagues in Perth actually came back and said, look, he went in there, he saw what he would put money on as being endometriosis, biopsy it, came back,
Clear.
clear. He did something I haven't seen done very often. He actually asked for a review of the pathology, and it went upstairs to a senior pathologist, and guess what it came back with?
Surprise, surprise. Which is why quite often the pathology services I use get two pathologists to look at the samples.
Yeah.
And then I'll actually ring up and say, are you really sure this is negative? They'll go back, they'll do further sections, they'll cut into it deeply, and they'll invariably say, yeah, we've found some.
Just someone hasn't looked hard enough in the first place.
Yeah. And sometimes it seems easy that these tests sound like they're foolproof, but any sort of test is not foolproof. There's always some sort of failure rate with everything.
Human error.
Yeah.
What are the long-term consequences of unmanaged endometriosis? Because we see a lot of people, they sit at home and will go to, wait for the next surgery if they've been diagnosed.
Correct.
But what about, I often hear mothers say, my daughter is lying on the floor, she's in a world of pain, she's nauseous, she's vomiting. Oh, I've got endometriosis. What should I do about it? Should I? Yeah.
We know that there's a genetic basis, there's an environmental basis, and there's an individual symptom appreciation, all of which are different in different people.
Yeah.
And that's where we come to this well-recognised figure of taking 7 or 8 years to get the diagnosis organised. But I also feel frustrated when people do go along and say to a general practitioner who may not be their normal person, a locum or a new practice they've moved to, and say, no, you're too young, you couldn't have endometriosis. But my mother's got it, my sister's got it, my grandma had it, my aunt has got it as well. Oh no, you couldn't have it, you're too young.
Hello.
I mean, how do you get around that? And often, particularly with menstrual cycle reproductive issues, it takes quite a lot of personal energy to say, hey, I've got real problems in my pelvis. It's a private matter. It's often disturbing relationships, intimacy, work problems, school problems. Kids are at school, sporting things. You just can't. You just laid low for 2 or 3 days per month. What happens in that situation is you get over it and you think, no, it can't be as bad as that. And you have 3 weeks or so of no symptoms and you think, oh no, I must have been imagining that. And
comes again.
And then a few of your friends will say, oh, you're a real wuss. Do something and look after yourself. Take some Panadol, take some Nurofen, take some something.
Yeah,
it might help you then, but your realization that your symptoms are not right doesn't necessarily get heard.
Yeah, we often talk about the missed and dismissed component of it, and that's a shame as well. But some of it is that while we see there are some issues on the, general practitioners are missing it. We know that for a fact. But we also have to understand that is not it's part of their training, but they're not specialised in that area.
Yeah. I just feel very, very grateful I'm not a general practitioner that has to have a look at a whole group. And I'm really grateful to the boys and girls that are in general practice who sort out many things.
They have to know everything, don't they?
Yeah, they do. Yeah. So if you think to yourself, I'm not being heard, just make your recalling of those symptoms say, hey, I reckon I've got endometriosis. You don't think I have, but I think I do. Can I have a referral?
Yeah,
I need to see someone, firstly, who knows about endometriosis.
Yeah.
It's very easy, and I use the mechanics situation. I haven't referred myself as a plumber.
Well, it is really, aren't we? We're just a series of pipes and plumbing,
exactly.
really, aren't we?
But let's face it, if something's going wrong in the house or the car, do you go and get an automotive electrician to help you with a Duco problem? In the house, if you've got problems with the plumbing, do you get an electrician? No, you don't.
No.
You get the person that knows what that system is doing and can then do things that are focused. You know, you might get the electrician that comes in and says, oh, I think you got a problem with your pipes, but I can't help you. Hello.
Hello. Not the right person.
Not the right person. So again, sometimes it can take a little bit of sorting out. And obstetricians and gynecologists like me, some people do 85% of their work delivering babies.
Yeah.
And they don't do any laparoscopic work. They don't do any pelvic floor work. They don't do pain work. And you can't expect those people to know the intricacies and the up-to-date research information with the drugs, the surgery, the additional interventions of what's around.
Yeah, and I often say to people recently, I've shared that I recently had surgery myself, and I'm actually seeing an ear, nose and throat specialist. And I'm getting sent to another one, but just specialises in a certain form of surgery.
Correct.
And it's the same with endometriosis. We've got, general, gynecologists that are more specialised. That's all they really focus on, and pelvic pain and that. So they'll see it more than an obstetrician who's basically delivering babies. So we have to be fair to those people as well, that there is differences.
Yeah, and the same thing with pain.
Yeah.
I have bladder specialists, bowel specialists, pain specialists refer patients to me for specific things that I do, like Botox into the pelvic floor, pudendal nerve blocks, sacral neuromodulation, and I can then support them in their aspects of managing the pain relief, the pain modifiers. I can use the muscle relaxants with the diazepam, and people go, that's really clever. I never thought about that. And, it's one of those things that is available, but one person can't think of everything all the time.
No, you can't. And I think that's really important, that there are other options. That people know there are other options like Botox. Up until a few years ago, I would never have thought of Botox into the pelvic floor.
And that's the same situation with diazepam, Valium, into either the vagina or the rectum for the muscles at the opening of the pelvis to help physically relax them. We know that back pain and shoulder pain, for instance, and neck pain will respond beautifully to diazepam, along with some anti-inflammatories.
Yeah.
But people sort of forget that the muscles at the bottom of the pelvis are muscles.
Yes.
And we can relax them. We don't take them all the time. We take them when the situation is out of control. We also use the trigger point therapy that the physiotherapists are fantastic at teaching people how to do it.
Yes.
But again, it's putting all the things together.
Yeah, and it's interesting what you said about the pelvic floor. And I think you and I see this a lot, that a lot of women will complain that everything's related to endometriosis. And I suppose on some aspect it is, but there are aspects where it is purely just the pelvic floor, like that pelvic floor hypertonus that you constantly see.
Yes.
Where the pelvic floor is like this, it's actually too tight. It's reverse to what we see postpartum and things like that.
And one of the situations is that there has been an enormous push about getting the core turned on and practiced and whatever, but a muscle contraction has got two aspects. It's got the contraction, but it's also got the relaxation.
Yes.
And everyone's turning on their core, making the muscles really tight, but rarely do they get taught how to relax those pelvic muscles.
Yeah.
And it's a matter of getting that balance between the two aspects.
And it is difficult to diagnose it, and this is why someone should see someone like yourself, is that, say, for instance, they could have bladder issues and they could have pain with intercourse, then they could have bowel issues, they could have just purely pelvic floor issues. It could be endometriosis, but distinguishing between interstitial cystitis, pelvic floor hypertonus, endometriosis, adenomyosis, they all pretty much have the same symptoms.
Yeah, I mean, there's got the three groups of organs in the pelvis: bladder at the front, uterus, tubes and ovaries in girls in the middle, or the prostate gland for blokes, and the bowel at the back. But all those organs are being controlled by the pelvic nerves, the pelvic muscles, and also the peritoneum, which is the lining that covers all those organs. And there's a whole lot of crosstalk between organs in the pelvis. And if one organ system starts to malfunction, I'll have a chat to the neighbours next door, and they will either go out in sympathy, or there will be a coexisting problem. And this is often what we see with endometriosis. And part of my routine management is to check the bladder in women that have endometriosis, because there is probably about a 30% chance that there will be some inflammation, some chronic inflammation going on in the bladder lining, which has been called urinary tract infections for often years and years.
Yeah.
But when we look at the bladder, we say this is not an inflammation caused by infection with bacteria.
Yeah.
This is a chemical irritation associated with the things that are in the diet that cause the inflammation in the bladder, which we call either bladder pain syndrome or interstitial cystitis, two names for the same thing. The treatment for that is not antibiotics, because there's no bugs there.
No.
And then we need to do the specific interventions for that. But unless we get the diagnosis right, we can't give the right treatment.
Yeah, and it's interesting that a lot of women will put up with a lot of bladder things, like they'll say, I'm frequent urinating, and then it could go the other way, they're infrequent and not able to avoid enough. Or nocturia is another one where we see women, they're up 3 or 4 or 5 times and they're not getting adequate sleep, which then adds to more or with the pain profiles if they're not sleeping. And then we're also dealing with other bits like incontinence. So they go through the full spectrum with it.
Yeah. So it's a matter of being able to get the right diagnosis, and it's often a complex, a multi-system diagnosis, so that we can treat each of those aspects on their own, but also altogether.
Now, we know there's no cure for endometriosis, and it is a very hard disease to treat, but we also have adenomyosis, which often gets missed and dismissed as well, and they both can be together there at the same time, which you see a lot of. And a lot of women will put off, maybe they've had all their children. Obviously, it's hard to do a hysterectomy when you haven't had children and there's possibilities of having future fertility. But what benefits could someone have from having, we say, look, hysterectomy doesn't cure endo, but it does help adenomyosis.
Correct.
So what benefits could they, even with endometriosis, hysterectomy provide to those people?
Well, the sort of symptoms that adenomyosis is going to give you are heavy bleeding, painful bleeding, sometimes irregular bleeding. That bleeding can be so heavy that you end up with passing large clots. And eventually that large amount of blood loss will lead to iron deficiency. And then iron deficiency, because you're losing so much iron, you can't get it in with your nutritional intake. You then need to be, or you will become anemic, where your blood count's right down. And the tiredness, the effort to just get around when your hemoglobin count is low and your iron is also low.
Yeah.
Women just drag around, and it sometimes surprises me exactly how women can manage on such a low hemoglobin. Yeah. So we've got oral iron, we've got iron infusions, and sometimes the blood count can be so low that we need to look at a blood transfusion to actually quickly replace a very low hemoglobin.
And I was seeing a lot of young girls that are anemic now for a couple of reasons. One is things like undiagnosed endometriosis and adenomyosis. Also to do with dietary things. A lot of girls are restricting calories and all sorts of different food groups that have iron.
Correct.
But I also know when I was sitting in your offices with my own daughter thought that heavy periods were normal. And it wasn't until you explained to her, how many pads are you going through a day? You know, how much flow are you getting? That
Are you passing clots? Oh, yeah, well, that's normal for me. I've always done that. Have you really always done that? No, it's happened in the last 12, 18 months. So it's then become normal.
Yeah.
But it isn't normal. And when you reflect back on what it used to be, you think, yeah, no, maybe this has cropped up, and I'm putting up with things that I shouldn't put up with.
Yeah.
And one of the problems is that someone will go along, let's say, for contraception, and just get a routine prescription for their pill, which they'll get made up every 12 months. And they won't be specifically asked about pain. And a lot of young women just won't volunteer that pain for whatever reason. They want to be strong. They want to make sure they're not being, like their friends would say, a bit of a wuss. And I don't have pain, so you must be just not coping.
Yeah, or the other,
just not the way it is.
No, this is it. And the other aspect is that we tell women is that period pain is common, but it's not normal. And like even my daughters thought, well, my friend said it's normal. So that's why they don't ask these questions.
Yeah. And we can take the edge off those symptoms with some Panadol, with some anti-inflammatory agents, perhaps some magnesium, perhaps a whole lot of things. But in fact, it's not normal. So let's have a look at it and work out why these non-normal symptoms are happening, and work out how we can modify that. One of the simplest reasons, or simplest ways that we can help heavy periods is with progesterone, and that progesterone can either be as a tablet, a gel, an intrauterine device. There's now 2 available in this country.
Yeah.
One is Mirena, the other one is Kylena, which is suitable for women that haven't had babies. It's a much smaller device that's much easier to put in. But these can revolutionise women's pelvic symptoms.
Yeah. And I think that it's very interesting that you brought up about the Mirena, because it was something I wanted to talk to you about. Quite commonly, we see the Mirena get blamed for a lot of things. Oh, I had the Mirena put in and it's made me crazy. Or I've had the Mirena in and it's causing all my pelvic pain. But what women have to understand is that post-surgically, after Mirena put in, a lot of that pain is actually just inflammation from partly the surgery, stretching the cervix that has never been stretched before.
Yep.
And there are simple things you can do to settle that down very quickly, like antiprostaglandins.
Yes.
You might have to take a simple course of progesterone for a little bit. Is that correct?
Yep.
And a lot of the time it isn't the Mirena causing you problems at all, but women will blame it, or they'll go online and go, oh, look, there it is. Someone else had the same problem.
Yeah. And just the human mind will say, right, this is the trigger factor. Whatever's gone on from them, all my symptoms are related to this particular time where maybe I got food poisoning and my bowel's gone wrong since then. Oh no, it was the Mirena. That went in at the same time. Therefore, every problem I've got is related to the Mirena. But in fact, it may be the underlying condition that we're using the Mirena to help.
Yeah.
So that you might need the Mirena plus some other interventions as well. Yeah. In fact, I saw someone yesterday, I saw a lot of people yesterday, who said, I want you to take my Mirena out. I've had it in for 4 months now, and it's giving me all these problems. And I said, oh, hang on, exactly which problems are they? And then we went through, and this is part of the importance of getting assessed properly. We went through all her symptoms that we had at the very beginning of this treatment phase. Correct. They were still there, and they were the ones that she was attributing to the Mirena. And I said, okay, what the Mirena does for us is give us a vehicle for a set and forget progestogen therapy.
Yes.
What you need is actually additional progesterone, which we could give you as a tablet, perhaps as an implant into your arm, but that's what you need. No, I want the Mirena out. The Mirena is causing everything. And I said, well, what do we do when we take the Mirena out and your symptoms are either worse than what they were now or no better?
Yeah.
I hadn't really thought about that. So we ended up taking the Mirena out, And my punch is going to be that she'll come back in 6 months and say, you know, that Marina was really doing a good job. Yeah. And of course, what the Marina will also do for people in the reproductive years is be a really easy set and forget contraceptive.
Yeah, and this is it. And it's interesting that you say, I know even with my own daughters, they said that, you know, it would have been easy to buy into the Dr. Google stuff. But a simple, like my own daughters, just some simple antiprostaglandins that you provide, and just a couple of days of extra progesterone, or maybe a month's worth of extra progesterone, and pelvic floor pain settle.
Yeah.
And then some pelvic floor, working with pelvic floor physio. That's all it was. It was the pelvic floor.
Yeah.
So it's very interesting that we get a lot of misperceptions, and this is why it's important not to buy into some of the Dr. Google diagnoses and see a proper healthcare professional, because a lot of the things you might think are causing your issues actually may have nothing to do with it at all. Yeah. So speaking about the next stage, we talked about the Marina and progestins. Tell us about the advancements in laparoscopic surgery and advancements in other treatments that have sort of opened up things to be able to help women with endometriosis here.
We often assume that things are pretty static in medicine. The sort of operations I do now weren't invented when I was training. They weren't invented when I was a junior consultant, a mid-career consultant, and now. So we've got things like the instrumentation for laparoscopy has improved. The visual quality of the images we see on the TV screen are so much better. The magnification's better. We're now introducing robotic surgery into gynecology. Hasn't necessarily been taken up as quickly as it has been in other specialties. Again, competent laparoscopists don't necessarily need that additional agility which the robot would give. So we've got those. We've also got a lot of research going on with medicines. Now, to be honest, in Australia, we don't have what the rest of the world has. We won't go into reasons why.
We won't go into reasons
it
why.
often's got to do with the wallet.
Yes.
But that doesn't stop research going on in other parts of the world with particularly the GnRH group of drugs, which don't have approval in the United States as yet, nor in this country with the TGA. But a time will come that they do. So that's there. The use of things like the Botox and diazepam is there. They work very well. And the other big group of drugs which were used in the past with really good effect, but unfortunately they had side effects of the dosage that they used to be used, were the trade name was danazol. It's a testosterone-based progesterone. Now, we make jokes about how blokes can handle pain better than women, but there is research going on in this country now looking at the androgen testosterone receptors in pain perception, and women don't have those at the same extent that men have. So if we can give a little bit extra androgen, testosterone-like products, to women as part of the pain management, pain control is better. The problem with danazol in the past, we would have used 600, 800, 1200 milligrams of the drug, and that used to be really pretty nasty side effects with oily skin, hair growth, weight gain, and they're not a pretty attractive side effects. But if we use a small amount of androgen and combine that with other aspects, we can help pain, we can help bleeding. We know that if we put a woman onto testosterone therapy, let's say if we think about our transgender patients, as soon as we put them onto their replacement testosterone, periods just stop.
Wow.
So, however, that is involved with a whole lot of other hormonal therapy. But in women who need to have menstrual management, if we give them just a little bit of testosterone-based therapy, In addition, it can be exceedingly helpful.
It's interesting you brought up the transgender thing because, again, you know, we're talking about people coming forth with information. If we had a transgender male who has previously, well, been female,
Born as female,
and sitting in the GP's office and just saying, I need this, this, and this, the GP might not be any the wiser that, well, actually, we've got female anatomy in there. This is a male, but yeah, so you see a lot of this.
In that sort of situation, there are specialist GPs that really are focused on looking after transgender health.
Yeah.
However, when I become involved and I do a hysterectomy as a gender affirming surgery for these blokes, when I'm in their pelvis, I find old endometriosis. So, having stopped the symptoms with their testosterone therapy, I then go back and after and say, hey, you had a lot of endometriosis. And they said, it's never diagnosed, but I always thought that I did. But because of my gender issues, I never really brought that up because that was something that was in the background. But my periods were terrible. My pain was terrible. And as soon as I went on to my testosterone, that all melted away.
Mm.
It's another way of looking at the way things are and the way the human body responds to interventions.
Yeah, because we don't often talk about the whole transgender thing with men having endometriosis, but yeah, they can. So it's very interesting.
It's a very wide-ranging discussion.
It is a very wide range. We can bring up some other time.
It's about sort of hormones are us, really.
Well, before we end our lovely conversation, what would be the top 3 to 5 things you'd say to someone that may be sitting at home with period pain, or maybe already has a diagnosis and sitting home in pain or other associated symptoms?
Yeah, I think the first thing is we have to realise that endometriosis is common.
Yeah,
about 15% of women have endometriosis, and when we start asking the questions, there will be a family history. Yeah. So if you think you might have endometriosis because of your symptoms, ask your family. Then we need to see you and assess those symptoms properly, effectively, thoroughly. Mm. So that's the group of people with symptoms. The other group of people, and I've spent a long time with these, is people wanting to have babies. If endometriosis is rumbling along and you know it, we want to make sure that we get not only symptom control now, but we want to avoid damage to the tubes, the ovaries, the rest of the pelvis for disease rumbling away untreated that may damage the organs there, so that when you do want to have babies, you got damage, and the only way we might be able to get around that is to resort to IVF. Mm. So if you're, now that's symptoms. Those without symptoms and you're having trouble getting pregnant, the standard things are that you would try for 12 months. And if you haven't conceived during that time, and we would expect 80% of people to have conceived, rather than just accept the advice of, oh, keep trying, let's get it looked at. Let's get the aspect of symptom-free endometriosis, which we find in 50% of patients who don't conceive. Yeah. Let's get those organised and assessed and treated.
Yeah, and let's face it now, as we are getting, people are conceiving later and later in life, the wait and see approach when you're in your 40s is not a good idea. You probably only want to wait months, really, or do something about it, you know, at least get some form of...
From mid-30s onwards,
yeah.
If you're planning to conceive and it's not happening, there are a whole lot of reasons. There could be sperm problems. There could be egg supply problems, so that we would want to do a level called AMH,
yeah.
To see what the store of eggs is. It's not perfect, it's not, and it doesn't correlate with the success of fertility treatment, but it says, "Whoa, your time is starting to tick over. Biological clock is running." And then we need to see if egg release is happening. You may have the eggs there. There may be polycystic ovaries, where the hormonal balance is not quite right. With fairly simple ovulation induction treatments, we can get egg release happening.
Yeah.
We can get the timing of intercourse properly organised. We may need to supplement with forms of progesterone to balance all of that. And if we can get those things organised short term, not wait months, years, but particularly in those middle years of the 30s, the biological clock is ticking over.
It is, very much so. And you brought up an interesting point about making sure that men are assessed too, because quite often they get missed or left out of the equation because the women are the primary driver. But it's very important to do them too.
Yeah.
All right, well, thank you very much for coming on today, Dr. Hall. It's been an inspiring talk. We've talked about everything endometriosis, right down to the nitty gritty. I think we didn't miss a thing.
I think we've had a good conversation, Andrew. And I'd love to come back and join you again another time if there's something we need to focus in on. We've done a whole range of things today, but we can focus in on other aspects if you'd like to.
Oh, I'd love to do that. We can talk about fertility and all the other things. All right. Well, thank you very much, Dr. Hall. Thank you for being a part of bringing awareness to endometriosis. It's very, very important. And we know that seeing people like yourselves are a very important part of that multimodality approach in helping endometriosis. So thank you.
Pleasure. Bye.